So should we start now?
Sorry. Sure.
Yeah.
Because anyway, it is recorded and then you can send the recording also. Okay.
Sure, sir. Bismillahirrahmanirrahim. Assalamu alaikum to everyone. So today we are going to discuss another common topic related to the newborn CNS diseases, which is brain injuries in preterm infants, and does intervention works, and what are the evidences. And today our speaker is a well-known personality. You all people know him very well. A bit introduction. Today's speaker is Professor Junaid Muhib Khan, and sir is American board certified in pediatric medicine and neonatal perinatal medicine, and he is currently working as director medical education and director pediatric residency program in SSMC, Mayo Clinic, UAE and USA. Sir is a fellow of American Academy of Pediatrics and fellow of Royal College of Physicians in Canada, and also he is an active member of Committee of Neonatal Resuscitation Program, and he has vast experience in the medical education, and he is a visiting faculty in Pakistan as well as Canada. He has a present at many national as well as international conferences as a speaker, and currently thanks to sir, he has come to us at Indus Hospital Karachi for a one-day non-invasive workshop. So over to you, sir.
Sure. So now you can see my screen?
Yes, sir. Sir, maximize.
Very good.
Yes, sir.
Yeah. Okay. So what we will do, first of all, thank you, Saeed. Always pleasure in a home country, home city of Karachi, and thoroughly enjoyed your hospitality that day, the learning enthusiasm, you and all your team. So what we will do, the topic is a little bit misnomer, is brain injuries, but it is focused to white matter injury, which is the interventricular hemorrhage. You can hear me well, huh?
Yes, sir. Bilkul.
Okay, thank you. So we can start and we can do do that, what we can do in our setups, which is meaning in our home country. I have to disclose that I have nothing to disclose, but maybe I, take some company names, but it is nothing to be related to this talk, but just for the necessity of this talk, that's why. There are a few objectives, but let's see that more focus on the pathogenesis and the neuroprotective strategies, that how we can tackle these issues. So I think it is touch base by Dr. Afshan, but I think it's not fully covered. So I'm going to give you, still the IVH is a big of a problem. So if you see in this slide, which is Barbara Stoll in 2010, NICHD National Neonatal Research Network, she published this study, and then Christian Poet in 2016, they said it 25 to 30% in VLBWs, and 15% of all VLWs have grade 3 to 4 IVH. I don't know if you can see the video. It is better to have a video. Anyway, so we can do that. Then very recently, like a month ago, 2 months ago, our own Naveed and Abdul Razak published this data, that severe IVH, often referred as IVH with ventricular distension or periventricular hemorrhage infarction, occurs in 7.7% of all of very preterm infant, and they define very preterm infants less than 32 weeks. But look at the less than 28 weeks, according to their collection of data, is 16.2%. which is not very different, which is almost 10 years ago here. You can see my pointer, huh?
जी
Any?
सर, जी जी.
Yeah, okay. So that's very good. So this is very interesting. I think because the prematurity rate is going up, or the more the gadgets, the more the smaller the babies we are trying to save. This number is hovering around over the past 10 years, almost the same. In fact, a little bit increase. So this is the U.S. Census Bureau and NICHD Neonatal Network, which is going to give the same idea, but I will give you the latest one, that how much the effect and how much is the sequelae of these things later in the talk. We have to understand that there are two types of the grading system. So what we are using is not the Volpe. It is called the Papial or Papi, if I'm pronouncing his name correctly. Volpe grading system made on percentages, that 10% small hemorrhage, 10 to 50%, and more than 50%. There is no grade 4 in this Volpe grading system. So do not confuse with that. Mostly we are using this one, with this Pebble grading system, subepididymal hemorrhage, IVH without ventricular dilatation, and I will show you in a minute, and grade 3 and grade 4, as you all know. So according to the Volpe grading system, the grade 1, major neurodevelopmental disability about 10%. The higher the grade of hemorrhage, the higher the disability and mortality. And then grade 3 is 80%, and mortality is almost half of the babies. And it is published in 2016. So these are the two main systems. This cartoon and slide showed by Naveed in his talk, but he talked about the circulation, which is very evident, that if you all remember to that. But I am taking to show you the grading of IVH. So you can see the pink here is the germinal matrix, and this is the choroid plexus, and the other is very obvious written on that. So if you have this one, they call it grade 1 or germinal matrix bleed only. If you go into this, into the ventricle without dilatation, as you can see here, it is grade 2. And if it is start dilating, as you can see here, is 3. And it is the post-ventricular hemorrhagic infarct, or outside the ventricle, it is grade 4. If you can see on the radiology or imaging, it is very obvious, as you can see, grade 1, grade 2, limited to the ventricles, very dilated, grade 3, and it is the parenchymal bleed. So this is very easy to understand and very easy to remember. I don't want to go through it. Christian Poet, again, in 2018, published about the mathematics or the economics of this condition, which is very horrible. It costs a lot of money, even in a very high-income countries like USA. So the problem is this, that if we can avoid these things, maybe if we can do something about it. Let's see, inshallah. Okay, where is my, okay. The timing of onset, it is published in 2015, as you can see here. After that, nobody, did any further work on that. And we are following the same. The 50% occur by 24 hours, 80% 48, and 90% 72, and by 7 days is 99.5%, and 20 to 40% have hemorrhage progression over 3 to 5 days. So still we are not doing, although in UK they are saying that because I talk to personally to Dr. Nikki Robertson, she's from UK. She said that you should do at day 1 the ultrasound. We are not doing it. We are doing it ultrasound at day 3, I will show you our guidelines which we follow. But anyway, but if the kids are very sick and we have to do it, then only we are putting the probe at day 1. Developmental anatomy, you all know the germinal matrix. What is the function of germinal matrix? The size of the baby or the gestational age increase, the germinal matrix is decreasing in size. Now, the pathogenesis is very important because once you understand that, especially the two things, the cerebral blood flow and the blood pressures and their relation to that. So we will talk about that, but there are a few other things. Of course, the infections and infection, ascending intrauterine infection is very much can cause the increased risk of the cerebral palsy, as you can see in this meta-analysis. It is by the Department of OBGYN in Germany. In 2014, it published. Increased blood pressure. This is a very old photograph from the old book of the physiology, the Guyton, and this is saying in the same thing that the mean blood pressure increase, the mean blood, effect of the mean blood pressure is also, giving the changes in the BP with the suctioning and all those. So hypercarbia, stimulation, tracheal suctioning, pneumothorax. These are all those things which we are dealing every day. And if we can do it in a right way, their management, we can avoid this severe pathology. So to gather together everything, intraventricular hemorrhage, pathogenesis, these are the 10 major risk factors from prematurity to respiratory distress syndrome, from coagulopathy to pneumothorax. Everything is there written. These are the risk factors and what happened, and it caused the hemorrhage in the germinal matrix. To make it more easy, just published this article in 2023. There are 4 things you have to remember. And if you remember these 4 things, you will be able to manage your baby and can avoid the IVH. Dr. Huck and myself talk about in one of the conferences about the gut and the brain axis when he was talking about NEC and I was talking about the feeding. But then in PPHN talk, I talk about the brain and the lung axis, and this is the brain and the heart axis. And these are these things, the cerebral blood flow fluctuations, cerebral vascular autoregulation, which we talk about hemodynamically, PDA and PaCO2. Vulnerability of the arterioles of the germinal matrix, we already talk about. Impaired cerebral blood drainage, which is this sign, the cerebral venous return, increased intrathoracic pressure and delivery mode. We will talk about it. Now, these are the things which we put the genetic polymorphism. Vitamin K epoxide reductase complex, APOE2 and APOE4. And there are many researches going on to give the gene therapy to prevent that. I will give you some data on that. But I want to focus on this one, endothelial nitric oxide synthase. So this is the system in our body, in baby's body, which produce the nitric oxide. This is one of the reasons the nitric oxide in a very premature babies, you have to be very, very, we have to be very, very careful about that. So this is the problem. Sorry about that. Okay, this is the problem about these. We shouldn't use nitric oxide in a very small babies. On top of that, they can give you not only the IVH, they can give you the what you call pulmonary hemorrhage. But this is different thing. But I'm just telling you related to the IVH. So first talk about the disturbance of cerebral blood flow and how you can prevent it. fluctuation in cerebral blood flow, high cerebral venous, abnormal blood pressure, passive circulation, all these things. The risk factor is hypoxia, hypercarbia, severe acidosis. So if you remember my talk on the HIE, this is the similar kind of a thing, that if you are maintaining the oxygenation, carbon dioxide, and do not overdoing it, do not putting too much pressures, do not putting too much ambu bagging, this is you can avoid. So focus on the carbon dioxide, blood pressure, fluid boluses, hypoxia, acidosis, and sepsis. The problem is that many of the centers here receive the baby, and at that time we cannot do it because many things happen before and during the process of resuscitation, which we will go through just now in a couple of minutes. To understand that, again, Dr. Afshan touched base on that, but I have to make it very clear that this is a auto-regulatory system we have when the kid grow up, and I will show you how it progress. So at certain point, if there is a change in the blood pressure, the cerebral blood flow is remains thing. But of course, as anything, always I ask just in the Indus also, the difference between distress and the failure. Our body can compensate up to certain limit. After that, we cannot. So that auto-regulatory system can work up to certain, but if it is blood pressure increasing and increasing, then it goes up, and this is the high blood pressure is one of the major cause of the stroke. How it's related to the babies and things. So this is the very published, I found it out, this very useful graph, the cerebral blood flow and the mean blood pressure. So look at this, how beautiful is the curve in the adults, how big is the plateau in children, also in neonate a little bit. But look at the premature, is a straight line. There is no auto regulation. So we have to be very careful in those babies, especially the 34, 32 weeks and below. I am not advertising the NIRS. I am using it, but I'm just giving you the evidence on the basis of the NIRS, near infrared spectroscopy, which give us the cerebral saturation or the tissue perfusion. Okay, and this is, you just put a probe on, like pulse oximeter on the forehead, and then you give some thing, which is, these are the values, but I'm not going into that because this is just a different talk. But I just want to show you that the coherence score, which is the relationship between correlation of mean blood pressure and tissue oxygenation index. So if it is more than 5, so as you can see, there is changes with the mean arterial pressure, the tissue oxygenation index is also changing, as you can see. And this is not good. It can cause IVH. As compared to it, is a very minimum changes. Coherence score is less than 0.5, and it is auto-regulated CBF. Similar type of thing presented by Shahab Noori is he did a lot of work. Young guy on the blood pressure, and Steven Siri, you all know, worked a lot on hypertension, and he was in Qatar before he came to us many times here in UAE also. So what they showed in this shaded area, when the IVH started, the cerebral oxygen saturation started decreasing, and the cerebral fraction oxygen of extraction is going up. So this showed you that if any changes in this hemodynamics of the cerebral blood flow can give you the IVH. There are a lot of studies about the blood pressure, and they are all very old, 2007, 2011, 2000, because it's an established fact that if the baby is doing fine, the perfusion is fine, you do not have to touch the blood pressure. You do not read the numbers. So in this study published in 2007, they said 23 weekers at that time, 93% received fluid boluses and 50% fluid 5% inotropic. We are using. Don't guess my age. It's my junior Ahmad Izar. He did it very nice. In severe brain injury and IVH of uh, we are not on risk of it is only recommend, but it's confirmed with the tissue region like oliguria, acidosis, especially then of course you don't have any choice. If there is any hemodynamically significant, I think Naveed or somebody did a lecture on PDA and they talk about that indomethacin, paracetamol or ibuprofen, you should treat study on the uh, uh, risk of the IVH. So these are the numbers which we put it. If the baby on severe cardiopulmonary disease, then 36% around 38, let's say give and take 40% hematocrit. If it is stable but oxygen dependent, then 30% if the baby is fine. And for a stable infant beyond 2 weeks, then 25% or 7 gram per deciliter is more than enough. We don't transfuse those babies. Platelet is another thing. We are transfused. It has also a consequences, but otherwise, it's 20,000 is the limit when you should transfuse the platelets. Third important thing is the hypercapnia. So this is uh, uh, one arterial PCO 73 grade 2, 74 grade 3, 80 grade 4. Why it is that happened? Because it happened in that time when we are saying permissive hypercapnia. So anything more than a certain limit is not good. So permissive hypercapnia to a certain limit is okay, but not to a very high limit. Why? Because the mean cerebral blood flow velocity is directly proportional to the number. 60 and above, the mean cerebral blood flow is very, very high. And the mean arterial blood pressure, as you can see here also. So this is a very direct relationship. So they speculate that the novel letter describing the effects of elevated arterial carbon dioxide on the capacity of cerebral autoregulation should raise concern use of permissive. So pillars of any especially showing so I like it the way they describe the silent, the saltatory and catastrophic. Mostly in our setting it is the catastrophic changes happen, but anyway it can present in many ways. The diagnosis is very easy way. Just put a probe and see thing, but 40 we is very so now we go this is the main lytics, beta symptomatic and magnesium sulfate, an endocrine treatment of maternal complication, as I told you about chorioamnionitis, ITP, or thrombocytic thrombocytopenia, or any condition which can cause the changes in the blood pressure of the mother, you should avoid. Now, these are the problem. It needs the good antenatal care of the mother. So this is the main thing which we are lacking in our country, in our setup, even in a bigger institutes also. Then obstetric intervention, control vaginal delivery, outlet forceps, we are not using it, anesthesia use or not use, I will show you some data on that, and then pharmacological agents on that. So come with the antenatal steroids. Antenatal steroids nowadays answer of everything, and similarly, it has a lot of effect on that. In the white is no antenatal steroid, and antenatal steroid in green. And as you can see that 22 weeker has no much effect. But let's say the and we don't recommend actually to do very aggressive thing on 22 week or even in USA also. So 23 weeks and onwards, as you can see, the antenatal steroid can decrease the death, IVH, and or PVL. And IVH grade 3 and 4 and PVL after NS exposure is much less as compared to the not antenatal steroid. So this is one of the things which we can say that even if the mother came and not much time to delivery, just give the steroid. I don't know, but may have some effects. This is the latest details on that published in 2023. And as you can see that it favors the corticosteroids as compared to the placebo, the IVH. But only with this meta-analysis, the problem is that the heterogeneity is more than 30%, which is a little bit iffy. But anyway, it gives you some idea that any corticosteroids can help in the prevention of IVH. Magnesium sulfate, easy, very cheap medicine. It's very evident. It's published up to date in 2019. It's a blockage of glutamate and activate calcium channel blocker, prevention of large blood pressure fluctuation, as we already discussed about that. And the big trial, 573 women, less than 35 trials in plus, and they found it out. It is very evident that it can have a neuroprotection. The number need to treat to prevent one case of CP is a little bit high, 63, but magnesium sulfate is a very easily available and very cheap. So it still is not that high number to me. We should, in the premature deliveries less than 32 weeks, we should use the antenatal magnesium sulfate, and we should ask OBGYN to have it. So these are the prevention strategies antenatally, the prevention of preterm, treatment of maternal, intrapartum fetal surveillance. As I told you that, of course, there is a lot of things we have to do at the OBGYN level, that they should do a lot of work to give to about it is also published in 2016 that it has some effect, but still there's a lot of debate on that. This is very interesting. As you can see, this antenatal is a cross-sectional study that it take as a cross-section. It the population. It published in the Internal Journal High Index, but it is from the Iran. Vitamin D, the higher the grade of IVF. This is a very good study. You can do it. It is not costing that much money. Okay, only the cost of vitamin D deficiency, vitamin D test in all the mothers, and see, especially the babies, if you think they're going to deliver less than 32 weeks. So these are the very interesting that vitamin D is also related to that somehow in this study. Stem cells we're not going to talk about. Then come to the intrapartum factors. Again, the maternal transport versus neonatal transport. This is not a brainer. In utero transfer is much higher than, but you know, in the children hospital Lahore, they don't have the OB born transport the baby. This is one of the things we or something. I don't know that big NICU without the OBGYN. Delayed cortical clamping, I will show you something. Antenatal steroids, we will talk about it, but asphyxia, again, this is related to the antenatal care. So this is this. They are talk about Eric Jensen is from the jobs now is working. He came last year to us also. So anyway, he mentioned that this the author recommend transferring high risk pregnancy to hospital with a high level of NICU in utero transfer with a high volume of very low birth weight deliveries. Delayed cord clamping, you know, the lot of advantages. Our NRP also now put it as a must, and not only that, it estimated 50% reduction in IVH with delayed cord clamping, and this is the study published in 2013. So delayed cord clamping, please ask your OBGYN. But if you need a resuscitation, then try to do it nearby, and you try second in those babies. And there's a lot of studies that favor the intervention, which is DCC. The another thing is umbilical cord milking is a lot of thing. Dr. Khatria published a lot on that. They said it is beneficial in the bigger babies, but do not do in the less than 28 week. Dr. Naveed study also showed that the higher incidence of IVH in those babies. Then after the intrapartum, then baby delivered now. So that's why I'm telling you that if the baby transferred to you, you miss all those opportunities to prevent the IVH. But at least who are delivering in your department, you can do it proper. So the proper resuscitation is very important. Whether you are following the NRP, whether you are following the NILS, whether you are following the new list, you have to be very comfortable without doing panic. You should do the certain things. So, for example, avoid the prolonged bradycardia, which is 180 seconds may be critical, which is almost, or not almost, is 3 minutes, and the time related low saturation levels 10 to 75th percentile during the process of establishing FRC. So, try to maintain the heart rate. If you have to do the intubation, first bring the baby heart rate and saturation, and then at a safe levels at recommended by the NRP or any resuscitation course, and then you should do the intubation. Do not give too much pressure, or do not pump the ambu back too much in a panic way. Just do breathe 2 3, breathe 2 3, something like that, and then you can give a very nice increase in the saturation and the heart rate. So the delivery room stabilization is a very important that you can focus on it to reduce the IVH, especially a baby less than 34, 32 weeks. Prolonged bradycardia, why I'm putting in the bold, because many times we are not looking into the heart rate that much. So please, we are more focused on the saturation. It is by default. It is in our system. So anyway, just prolonged bradycardia less than 80 or less than 90 at that critical stage is not good for the baby. Okay. Neonatal factors. Now the baby delivers and the baby is sick. There are many neonatal factors. We will go one by one. Neuroprotective care. So appropriate respiratory support. So if the baby needs ventilation, if the baby needs non-invasive, we have to be very careful about that. Saturation and carbon dioxide monitors, UAC, UVC sampling. The golden hour is there, that we have to complete everything in 1 hour and leave the baby alone and stabilize the baby. Even the diaper changes, I mean, this is just for information. They said that even the change the diaper by flexing at the knee, flexing at the hip, not by raising the legs like that. So even the small things can gather together and prevent it. So first of all, as soon as the baby deliver, our nurses, our RTs, respiratory therapists, if you have, and ourselves, we try to give the suctioning. So there is no, this is from the Cochrane 2016, there is no evidence or insufficient evidence to identify the ideal frequency of ETT. So we have to be very careful, because it can change the pressures, the cerebral blood flow and the blood pressure, which can affect the risk, which is one of the risk factor. Future research effect of suctioning frequency on very preterm infants' lungs and brain. There are one or two studies I know, but it's still the results are not that very good. So avoid suctioning. If there is a need, of course, do it, but do not do the deep suctioning, especially initial in the critical stages. There's a lot of talk about it. Is the old study about the midline position, but it is the part of the neuroprotective bundle or IVH protected bundle. I think Professor Huck will talk about it in the last talk of this session, in this, of course, this module. So what these studies also suggest that if we put the baby in the midline position, then it is healthy, especially if the baby is less than 1200 grams. No adverse consequences identified for this procedure. Now, the ventilation, I don't have to talk about that. The ventilation is not good because it's higher intrathoracic pressure, reduced venous runs, suctioning. On top of that, hemodynamic changes, hyperinflation, and all those can, and carbon dioxide perturbations of the changes can all is the very high risk factor for this thing. So this is the old study with 2012, almost 10 years. Hani Ali from, at that time he was in Washington, Brain and Development. He did this study and they found it out, the lower birth rate, mechanical ventilation and cumulative duration of mechanical and ventilation. Intubation in DR increased the risk of severe IVH. The odd ratio is very high. So as you can see in this thing, in this study. So of course, the ventilation is one of the things. Then in 2018, January, again from Edmonton, Alberta, they find it out that the high tidal volume delivery during the mass PPV, as I told you, do not give too much pressure. it was associated with the brain injury, and strategies to limit this thing during mastectomy PPV should be used to prevent high thyroid. So if you want to invest on new puffs. If you want to invest, there's a bamboo bag available with the pressure meter on it. Try to invest on that instead of cooling or ventilation or something like that. Surfactant. Of course, we are giving surfactant. It is presented by Dr. Holiday that the surfactant has affected, decreases the rate for IVF. Dr. Holiday is very biased towards surfactant. He's the very senior neonatologist. He's from Ireland. He did a lot of work in the Curacao. I think so he liked to give surfactant. So it is the meta-analysis of prophylactic surfactant. We are not giving prophylactic surfactant. We are giving early rescue surfactant. If the baby needed, is the failure on the CPAP or this thing, then we give it. But he showed some effect on of the surfactant in IVH. So this is the study which I talking about the RBC transfusion given before IVF, and if you we are related 30 hematocrit if the baby is on CPAP or oxygen, and if baby is fine, then 25% is more than enough. So avoid too much giving aggressive transfusion. Comfort measures, the pain, stress, swelling, of course, this is all have it. Even the quiet, dark environment can help, but I don't know, in our nurseries, if you see the crowded nurseries, forget about the cot, in one bench, there are 3-4 babies are lying down. But anyway, these are the ideal condition we have to maintain. So to prove this, I just put it is that the role of environment is there. The calmer the environment, the better the outcome at Bailey cognitive scores. So let's say who is developing the new NICU, like Sajid doing it, he can develop something like that with quiet rooms and all this thing because he's developing the new unit around him. So this is the summary of the meta-analysis from the Dr. Naveed study on severe intraventricular hemorrhage. Antenatal, we talk about corticosteroid, the grade is moderate. Dexamethasone versus betamethasone is moderate. Repeat antenatal is, of course, moderate. Magnesium sulfate also they give moderate. Antibiotics is a low for the rupture of the membranes. And the cesarean delivery versus vaginal delivery, they don't have the data, they put not available. But the thing is that there is few studies which show the cesarean section get in the babies, very small babies, is it chances to have less IVH as compared to the vaginal deliveries. Then they talk about the delivery room interventions. As I told you, lower versus higher FiO2. The higher is better, which is 92 to 94% saturation. Sustained inflation, they give, but we are not doing it. Delayed talk about milking, we talk about, and as you can see, the caffeine prophylaxis or the treatment for apnea post-activation is also have a moderate effect. These are the main things which Dr. Naveed published just very, very recently. So antenatal steroid, indomethacin prophylaxis, we are not using, but still there is one study other than that showing there's a good effect, but nobody using indomethacin prophylaxis nowadays. Volume targeted ventilation has a good effect. The certainty of evidence is low, but still we all recommend that if you have the chance, do it volume targeted ventilation. The early erythropoiesis stimulating agent is also a good, but we are not using it. Similarly, the ethamesylate is also, we are not using it. And as I told you, in a very small baby, more than 28 weeks, umbilical cord milking increase the incidence of IVH. Caffeine, this is going to be published in September 2023, which is next month, that the caffeine has a very good effect in decreasing the IVH. And they did the study on the rats that this the dilatation. I don't want to go if rat have the caffeine, uh, no caffeine. This is our IVF prevention bundle. I will leave it for Professor Haq, and inshallah he will talk about it. These are very, very small things. So these are one thing. We publish our by using the bundle of the care in the Saudi Journal, like 1 year ago or 1.5 years ago, and it shows a real improvement in the IVH. And I think why is, benefit one, but there is one study in just came now. I forget which year, but anyway, is in favor of prophylactic indomethacin. Complication, you all know, periventral leukomalacia, PVH, dilatation, as you can all see. Now, need of integrated program stance, and but unfortunately persistence of progress and after intervention like reservoir and deeper different shunting. Diagnosis and the management of this very quickly, these are for those who are interested in head ultrasound. We have to measure the ventricular index, anterior horn width, or thalamocortical occipital distance, which is this one, and then go accordingly. So I will show you this is the pathway. I will send it to you and you go through it. I don't want to go to that, but this is the thing we are following it. Green zone, yellow zone, red zone is like a traffic light. So if the ventricular index is less than 97th percentile and anterior horn width is less than 6 millimeter, it is in the green zone. And this is the graph which we are using, the 4 millimeter above the 97th percentile, then we try to. And this is the yellow, and this is the red zone, that when we have a serial management. So if we use, of course, grade 3, grade 4 IV time to time, but thank God not that much. If you use this time, then everybody should remember this guy. His name is Ayub Khan Umayya. It's nothing to do with military setup. So he's the one who, from Peshawar, who invent this reservoir, which is we are using. It's in 60s, which we are using also just to do the frequent tab. If you do the frequent lumbar puncture, it is very chances of infection is very, very high. But with that tab is much lower, and you use the guidelines which I showed you, the green zone, the yellow zone, and the red zone. If not improved, then you have no other idea, no other option to put a shunt. The shunt is like a coil, is the ventricular peritoneal. So the uh, uh, CSF is drained and the kid grows up. The from the United States published in 2022, increasing severity that 40% for grade 1. So even with the grade 1, you cannot say this but this if the baby has grade 1 hemorrhage and it is not progress and nothing, no management further needed, the outcome at 5 years is the same. There's other data also we have to talk when we talk to the parents. So 18 to 22 months post-menstrual age, grade 3 without shunt, with shunt, and PVH, it is increasing with very ventricular chorus, periventricular. So CP, German IVH, the deficit is not that significant on that any IVH what will happen. Then and this dysfunction is significant. Refraction error is not that much. Stigmatoscopy is there, yes. And of course, the gross motor. Preterm but not avoided and delivery room sterilization, as we just talked about, just a little things, this thing. In addition, if the baby have a seizures, you have to manage it appropriately. These are the routine administration. Please try to have it. Antenatal steroid, magnesium, maternal transfer, if it is possible, transfer the mother as compared to the baby, which can decrease the likelihood of the IVF. In addition, incorporating neuroprotective care bundle, which inshallah Professor Haq will talk about, which also decrease the IVF. And these are in that bundle also, these are very small things. For example, just take a blood slowly from the lines and push the, flush very slowly to the lines. So last thing, it is by Malcolm Levine that the reduction of the interventricular hemorrhage is a real only if a complex of measures or the, whatever we discuss now is implemented into clinical practice based on a deep knowledge of pathophysiology. So always listen to your seniors, not me, but Professor Haq, who was more talking about the pathophysiology and pathophysiology. Then you can do, you can prevent this multifactorial serious disease. I took too much time. Thank you very much. Sorry that I changed a little bit of the time. If you have any question, I saw Naveed is there. Ask Naveed. Thank you, Saeed.
Thank you so much, sir. It was, I think, a really wonderful presentation. Sir, here are a few questions. If you allow, I can start.
Sure, you can start.
So one question is, if once IVH is detected on the POCUS, either grade 1 or 2 or 3, then when need for the progression or resolve of IVH?
You have to do the serial thing, and which the graph I showed you, okay? Which the graph I showed you, or our protocol, it is written when to repeat it, okay?
Right, sir.
So it will take time to resolve. It depends how it is, but the grade 3 fully resolved, I cannot tell you, but you have to do it. In that our protocol, up to 92 days, we are doing the serial ultrasound, if possible.
Right, sir. So another question, what is what's the recommendation of voice control in NICU? It's also increase the risk for IVH. So how we
This
can control in resource limited setup?
अच्छा जी, तो इसका जवाब सिंपल वर्ड्स में ये है कि इट ऑल कम इन टू द एनवायरनमेंट. एनआईसीयू में आप घुसे, नर्सें टहके मार रही हैं, कोई ठट्टे लगा रहा है, कोई पॉलिटिक्स पे बात कर रहा है, कोई जो है पता नहीं किस चीज पे बात कर रहा है. सो डू in a very low I forget the frequency, maybe Naveed or Professor Huff knows about it. Put it at that thing, the decibel of your voice. So do it at a low tone. ठीक है ना? Even some thing called which I have my own interest, but anyway, that is, people want to put the Quran near the, so it's in the low voice, okay, not in a very just high voice. So if you can control this thing very easily, similarly the light control,
Right.
okay. So people are not taking care of these things. Sometime I thought they come in the round, I saw myself and just hit the like this, the incubator. Why you did that? What is the reason? You want to wake up the kid or what? Believe me, this has happened. Okay.
Right, sir.
So this is the answer to the question.
Right. So another question is, Dr. Nasir Rashid, he's saying it is a great presentation. Just want to reiterate that less invasive approach, whether in doctor, DR and in ICU, with CPAP is the key. Acha.
Yeah.
So, one more question.
So this is the thing. Anything is less invasive, okay, from ventilation to monitoring. Okay, so that, for example, we have PCO2, okay, we have, sorry, pulse ox. If you want to measure the PCO2, don't do every hour blood gases, okay, just procure antidal. If we don't want to know that many things. I saw many in nursery, even in the USA, every 6 hours they are doing the blood gas. For what you are trying to achieve on that, but you don't know how much taking the pressure and giving the flushes through the lines can increase the risk. So Nasir is, very much right in saying this, that of course.
So one more question is, sir, could you please share your experience about the use of Omaya reservoir in your setup, as we often get it complicated with ventriculitis?
But yeah, this is you have to control. We don't have any ventriculitis up till now. Even here now, I almost 10 plus years here, 12 years. We put Omaya reservoirs. We don't have any ventriculitis through that. So just a strict hand hygiene. That's simple as that. When you do this thing, do a straddle, disposable needle. Just take care of any other infection control thing. I think this is the very good invention, because to do an invasive procedure like lumbar puncture again and again is a very high risk of the infection as compared to this.
Right, sir. Sir, one more question. Is there any role of istazolamide like in case of the PVHD?
This is referred to Naveed. I don't have any idea about that.
Right, sir.
I'm sorry.
No.
Or Professor
Naveed is
Khan is
also
also
here.
there. Sir also here. Or
Yes.
Nasir Rashid is also there. Oh, so big, all stalwarts are there. So they can answer this question.
Right, sir.
I took
Yeah.
easy one.
Thank you, Dr. Junaid, for a nice presentation. Yeah, I never heard of like what will be the mechanism for this acetazolamide.
Right,
But
sir.
you are
It is
using? Huh? And Naveed, you are using it?
no, we are not using like the use of acetazolamide in NICU. I never heard. We should never use it even for like alkalotic babies as well.
Yeah. Yeah. Okay.
Right, sir.
Yes, Said?
Yes, sir. I think questions.
Yeah.
So one more question, but it's not, I think, related to the IVH. Here is a question asked by one of the participants. Can we give the
Hmm.
prophylactic phototherapy to preterm who are on risk like ABO or RH?
To me, no. Like again, any one of our seniors like Naveed, Khalid, Professor Khalid Haq or Nasir, we never use prophylactic phototherapy unless until we have it. Sir,
Right.
you have any idea about that?
We don't know. We would not recommend prophylactic phototherapy. And as far as acetazolamide is concerned, that is historical. It used to be used. We have used it in the 1960s, but it was given up something around 1972, 73. So there is a historical evidence for that. But for instance, mid-70s, we have never used it.
सर तो 1960 में तो मैं भी पैदा नहीं हुआ था, लेकिन है ना ये आजकल के बच्चों को कैसे पता चल गया एसिटाजोलामाइड का?
किताबों में है इसलिए है।
सर बिल्कुल।
लेकिन it is not used. I mean, I'm giving up my age for you for this, but I have used it in late 60s and early 70s, but after that it has not been used.
Sure. Okay.
Some questions are, I think, completed in chat box. If anyone want to
Anything
ask,
else? Sir, any comment?
MashaAllah, very nice. Thank you. But you were only concentrating on IVH, but there are many other brain injuries, which I suppose other people will talk about, inshallah.
Inshallah, because this is order from Saeed that we should focus on only on the IVS. So I said, okay, that's it. Because there are many other things. I think in the second talk of the Naveed, inshallah, it will cover, and in the end, you know what you call in the fashion shows, the show stopper is Professor Ha. Inshallah.
Inshallah.
No, I will only be talking about functional abnormalities. So
Okay.
don't worry.
Okay. No, inshallah, your talk will cover everything. So,
any question from audience, please? I think no.
So if anybody have any
I think no, sir. So, sir, we are concluding the session. If you allow, so, sir, can you hear me?
Yeah, I can hear you.
So thank you so much, sir. I think it was very really wonderful presentation. I personally learned a lot of things today. I hope all learned today a lot and will learn from our YouTube channel,
Inshallah.
recorded video. Thank you so much, sir, and thank you so much, Professor Khalid Haq and Dr. Naveed Rahman Durrani, Sir Nasir Rashid, and all our respectable participants. So inshallah, next week, our topic will be, sir, neonatal herpes encephalitis by Dr. Nasir Rashid. So inshallah.
And the time is the same.
Sir, 9 p.m.
Sure.
Sir.
Okay.
Ji, sir.
9 p.m. Yes.
Yes, sir. So inshallah, sir, till that, Allah Hafiz, and thank you once again. Ji, sir. Allah Hafiz. Thank you.